Hello, everybody, and welcome to today's podcast where we'll be talking about non-pharmacological interventions in diabetes care and the technology advancements in diabetes as part of our Diabetes Week. So I'm absolutely delighted to be joined by our clinical associate, Georgina Parisi. So welcome, Georgina.
Thank you, Preeti. That's a lovely introduction. My name's Georgina. I'm actually a community diabetes specialist nurse, and I've worked in that role for almost 12 years. The role is quite wide-ranging, so in the past, I've gone into general practice to support practice nurses. I run specialist clinics for people with type 1 diabetes and type 2 diabetes. And I'm a type 1 diabetes educator, delivering courses such as Daphne.
Brilliant. So a wealth of experience there. And obviously you also support our learners at Education for Health to really build their knowledge and skills around diabetes as well. So welcome to today's podcast. So let's start with non-pharmacological interventions. So tell us a little bit about the role that non-pharmacological interventions play and why they're important in diabetes care and some of the advancements that we see today in today's world in terms of non-pharmacological interventions.
Okay, so we've got to think about what non-pharmacological means, first of all. So it's really any way of supporting people to manage their diabetes, and particularly type 2 diabetes, which will be the focus for the next few minutes, without the use of medications. Personally, I see this as 4 key sort of areas: diet, activity, structured education, and finally, emotional and psychological support. But today I'll be focusing on diet and activity. I would put a disclaimer. Please remember that the strategies I'm going to talk about in the next few minutes are for people with type 2 diabetes. People with type 1 diabetes, their only treatment option is insulin. This should never ever be stopped. And the dietary input for them is primarily around carbohydrate counting and matching insulin to carbohydrate. So dietary management for type 2 diabetes can be fraught with emotion and misinformation and a bewildering array of different approaches. Many people with type 2 may feel judged about their dietary choices, especially if they also have obesity. So it's important we consider the evidence base for any advice and support that we offer. After all, we wouldn't offer medication without any evidence that it works and has a good safety profile. The good news is that we now have some sound evidence based on clinical trials and a prospective study. So let's have a quick look at some of these. So one of the most significant ones is something called the DIRECT trial, which was led by Professor Lean and others. And this is a medically supervised program carried out in primary care where participants followed a low-calorie diet of approximately 800 calories to start with, and normal meals were gradually introduced in a stepwise way. Entry to the trial was for those aged 20 to 65 who'd had type 2 diabetes for less than 6 years and a BMI of 27 to 45. The trial demonstrated that weight loss and remission of type 2 was achievable for many participants. And 6 to 7 years later, the trial is still demonstrating that weight loss can lead to improved metabolic health, and again, that remission of type 2 diabetes for some. After only 1 year on the trial, 46, so nearly half the people in the trial had achieved remission. So that's an HbA1c below 48 on no medication. And 70% of those were still in remission 12 months later. So the new NHS type 2 diabetes path to remission programme to treat people with obesity and type 2 diabetes is now being rolled out nationally. And it's based on evidence, mainly from the DIRECT trial, but also from another trial which was called Droplet, and this was for people with obesity. And this diabetes path to remission programme should be available to everyone by early 2024. So you may already find that you can refer directly to this from primary care. I'd also like to give a quick mention to something called the Retune study. So this was carried out by the same team that did the direct trial. And this was a very small study looking at 20 participants with type 2 diabetes for less than 5 years, but these were people with a BMI below 27. So we know that about 10% of people with type 2 diabetes have got a normal BMI or are only slightly overweight. The people in the trial were found to have a higher than average amount of fat surrounding the liver and the pancreas. And as they underwent the trial and lost weight, that fat decreased, and about 2/3 of the people in the trial achieved remission. So that was really promising for those people who aren't necessarily seen as overweight or obese. So the low carb digital programme is a slightly different approach, but this was developed following work carried out in primary care by Dr. Unwin and others. There's currently a 3-year single-arm prospective study with 1,000 participants who are undergoing the low carb programme. The study is still ongoing, but there was a 1-year peer-reviewed outcomes that demonstrated the programme to be effective for both weight loss and reduction of HbA1c. And about half people in the study so far have been able to stop or reduce their diabetes medication, which is very promising. So there we have 2 approaches to weight loss for people with type 2 diabetes, either a low carbohydrate or a low calorie. However, not everyone will be suitable for either of these programs for a variety of reasons. People may have other medical conditions, they may have eating disorders, or they may not be able to access the digital platforms. With that in mind, we have the new Dawn project, which is developing a range of effective weight loss options for people with obesity or overweight who are newly diagnosed with type 2 diabetes. This project is being run jointly by the National Institute for Health and Care Research in collaboration with Diabetes UK, and hopefully that will bring forward other strategies so that we can make a weight loss programme more accessible for people with type 2 diabetes. So I'm just going to very quickly talk about activity. So we often think of, the mainstay for type 2 diabetes is diet and activity. What do we mean by activity? I prefer the term activity to exercise, as all movement can be beneficial for people with any type of diabetes. The NHS recommends 30 minutes 5 times a week of moderate activity. So that's activity that gets you slightly out of breath, a little bit warmer, slightly increases the heart rate. And we know that this will increase insulin sensitivity for many hours, thus reducing blood glucose. However, we have to remember that some of our patients with diabetes may be frail, could have comorbidities such as respiratory disease, cardiac disease, neurological and musculoskeletal conditions. And this will make what we consider exercise quite difficult, but we can still encourage them to be as active as they can within the limits of their condition. This is sometimes called an activity snack, and I love that term.
That's a very interesting term, isn't it?
It is, isn't it? Yes. So it's actually just about encouraging people with diabetes to sit less. And we should all probably do that. And perhaps when we finish listening to the podcast, we'll get up and have a little walk.
Or you can listen to the podcast while people are walking.
Well, even better. Great idea. So we know that it's already been demonstrated that short spells of activity will help people with type 2 diabetes reduce their glucose. And there's been a recent study of people with type 1 diabetes, and this was supported by Diabetes UK. And they found that breaking up an extended period of sitting with a 3-minute walk every half hour decreased their average blood glucose without causing hypoglycemia. And I should mention that fear of hypoglycemia is a big barrier to people, especially those with type 1 or anybody else on insulin. It's a worry, and it is a barrier to them partaking in exercise.
That's great. So I guess, one of the key things that we've talked about there is some of the trials that are supporting these pharmacological and non-pharmacological interventions. But I think one thing that's really clear is whatever intervention we choose to take, it's taking that person-centered approach, isn't it? So making sure that we're recognizing that person's beliefs, their own values, their cultural beliefs, their religious beliefs, that perhaps will help shape the interventions that we choose, or we make that decision with the patient as to which intervention would be the most appropriate for them. So I guess talking about some of these non-pharmacological interventions, what have you seen that you've applied in practice? So taking this knowledge from some of these, from some of the literature we've seen, some of the guidance documents, how has that really played out in your area of practice? So what have you been doing in your locality to help drive some of these non-pharmacological interventions?
Okay, so I'm actually part of a multidisciplinary team. So we actually deliver structured education for people with type 2 diabetes. And the big focus on that is weight management, because there is clear evidence that weight reduction will help improve outcomes in terms of reducing HbA1c and perhaps reducing medication. And I often see people with type 2 on insulin in clinic who are undergoing a weight management. They might have perhaps been referred to somewhere, one of the commercial weight loss programs by their practice nurse, and then need their insulin adjusting because they've reduced their need for all those medications, including insulin. So within your own area, there'll be a wealth of places that you can refer people to, and hopefully in the next sort of few months, the NHS remission program, but also those commercial weight loss programs, or if it's a little bit more complex or people aren't suitable for groups, and a lot of people aren't due to their perhaps mental health conditions, or there may be language or cultural barriers. We offer support in a wide range of ways, with one-to-one clinics and things like that.
That's brilliant. And I think it really emphasizes, doesn't it, the importance of that multidisciplinary team approach. And, for some areas, they've got their dietitians that really support with these interventions. You've now got other roles such as pharmacists that support with, the pharmacological interventions. So I think it's really about using the knowledge and skills of that multidisciplinary team to really drive the outcomes for those people living with diabetes. So that's brilliant. And I think we talked a lot about the non-pharmacological interventions, but as with any long-term conditions, the role of technology seems to be becoming more and more imperative, and we can use technology to really support the positive outcomes that somebody has with long-term conditions. And I guess that's no difference for somebody that's living with diabetes, because there's certainly been a lot of advancements in technology in this arena. So talk to us a little bit more about the advancements that you've seen in technology within diabetes.
Okay, so the developments in technology are moving really, really quickly, and even within a specialist role that I do, it's actually quite hard to keep up with it all. So there's been some massive developments, and this is mainly around support for people with type 1 diabetes, to be honest. So a couple of things that people will probably be seeing already in primary care are the flash glucose monitoring and continuous glucose monitoring systems that are now available for anyone with type 1 diabetes in England and Wales who wants to avail themselves of that. So the common systems that we're seeing at the moment are the Freestyle Libre and the Dexcom One. There are other brands around, and we will start to see those sort of coming into the market as well. But I think the Libre and the Dexcom One are probably the most commonly available at the moment. And they've sort of been appraised by NICE and approved for rollout. So just a little bit about how that technology works. So both the Freestyle Libre and Dexcom ONE are available on FP10 now. They involve wearing a sensor which is attached to the skin, but there's a little plastic filament that goes under the skin into the subcutaneous tissue. And this filament is measuring what we call the interstitial glucose every few minutes. So it's slightly different to the blood glucose, and there will be a slight difference in the values. The difference will be most marked at extreme values. So if, for example, the glucose is very high or the glucose is very low, say at a hypoglycemic level, or if the glucose is changing rapidly, you will see a little bit of a difference between the interstitial glucose value and the blood glucose value. However, the beauty of the sensors is that it's showing trends. It's not showing just that on-the-spot glucose. It's showing where the glucose has been. So the glucose values in the Libre 2, which is flash glucose monitoring, are retrieved by scanning the sensor. And when you scan the sensor with either the reader supplied or an app on a mobile phone, all the values over the previous 8 hours are uploaded onto the device, so that the person can see not only the on-the-spot glucose value at that point in time, but there'll be a little graph showing where the glucose has been, and there will also be something called a direction arrow. And this is predicting where the glucose is going. So they might have an arrow that goes straight across, meaning the glucose is quite stable, or they might have an arrow going up or down. And this helps the person with diabetes to make decisions around insulin dosing or taking carbohydrate. The Libre system can provide graphs, it can provide average glucose data, and even an estimated HbA1c once there's enough data on the system. And this helps the user to make those safe and meaningful decisions based on what's happened, rather than just that on-the-spot glucose test that they would get if they did a finger prick. I would say that people using this technology will need to access blood glucose test strips and lancets in case of technology failure, or in case there's a very high or very low glucose. They also need a large sharps box because the applicator for the technology is quite large and it contains a sharp during application, and that needs disposing of. So the Libre system has a sensor that lasts for 2 weeks, so people need 2 of those sensors a month. The Dexcom ONE, which has come out more recently, is what we call a continuous glucose monitor, as no scanning is required. It still has a sensor that sits on the skin and a little plastic filament that goes into the subcutaneous tissue, and it's reading the interstitial glucose levels. Where it differs from the Libre is that obviously that data is transmitted directly either to a reader or to an app on a mobile phone, and the sensor only lasts for 10 days. So people will require 3 sensors a month. There is also a transmitter that plugs into the sensor once it's been applied to the skin, so it's a little bit more fiddly, and that transmitter gets reused, and a new one is required every 3 months, and all those things come on FP10 now. And again, as with the Libre, people will still need access to their glucose test strips in case of emergency. So these are available for people with type 1, but there are some people with type 2 who can also access this technology, but it requires approval from the Integrated Care Board at the moment. So anybody with type 2 on multiple daily injections who either has severe hypoglycemia or impaired hypoawareness, if they have a condition or disability such as a learning disability or cognitive impairment that means they can't self-monitor, or if they've been advised to measure at least 8 times a day. There are also criteria for people with who are pregnant or who are on dialysis, and that's all available through the NICE guidelines. So what are the advantages of this technology? So it feels quite obvious, doesn't it? Many people report that it's changed the way they manage their diabetes and it's improved their quality of life. They may well have been finger pricking 8 to 10 times a day, but even with that frequency of checking, it's still a little bit of guesswork. And now they've got much more data to inform their decisions. The data from both systems, the Freestyle Libre and the Dexcom one, can be uploaded to a web-based app. And this is accessible not only by the user, but they can give permission to their healthcare practitioner, either within a specialist team or in primary care, so that they can have a meaningful consultation, either face-to-face or remotely. The Libre 2 and Dexcom 1 both have high and low alert alarms, and this has been massive for people who have previously experienced lots of hypos or have lost some hypo awareness, because they can now set an alert to warn them in advance, and that has made such a difference to people. You know, in busy workplaces, it's allowed them to sort of prevent hypos happening. So we can't underestimate the quality of life changes that's brought about. There is training on both systems for users and healthcare professionals, and I would thoroughly recommend you not only signpost your patients to that education, but also access it yourself so that you've got a better understanding. There are a couple of disadvantages, as with everything. So some people start to get skin reactions to the adhesive, and that can be quite tricky. People with a very limited dexterity may struggle with the applicators and actually attaching the sensor. But if they've already got a relative or a carer who lives with them, that's sort of easily overcome by somebody else attaching that. And finally, people can get quite overwhelmed by the amount of data that they first see. If they're used to only getting four bits of data a day, and suddenly they've got all these graphs and they can see all the variations in their glucose, that can be quite frightening and alarming. And they may start overusing their insulin to try and address that, and end up giving themselves hypos. But overall, it's really, really beneficial for people with type 2 and those with, for people with type 1 and those with type 2 who can access it. There are other continuous glucose monitors available, but these are generally accessed in secondary care, and they're designed to work with pumps, so they need sort of prior approval funding. Quick word about pumps. So you will come across people in primary care who are using pump therapy. So they're for people with type 1 diabetes who meet the required criteria. People on pump therapy will still need to keep an emergency stock of insulin pens, both their long-acting and quick-acting, and a few needles in case of pump failure. If the pump fails, that person is immediately got no insulin on board because their pancreas isn't working, so they need that back up very, very quickly. So you will find that those items may still be on a repeat prescription. People using pumps will still need to carbohydrate count and tell their pump how much insulin to give. So it's not, it changes life, but it's still a lot of work for them. We now have something new called a hybrid loop system, which is being piloted in some centres. You may or may not have heard of this, or you may have patients coming along and asking for it. This involves a continuous glucose meter talking to the insulin pump, and an algorithm either in the pump or on a mobile device telling the pump how much insulin to administer. So you can see there's lots of new developments for people with type 2 diabetes and for people with type 1 diabetes. And I think, as you said earlier, these all make a difference to people's quality of life as well as improve their short and long-term outcomes.
Great, thank you so much, because that's a really good overview of some of the technology advances and actually how they've supported patients that have diabetes, but equally around the role that we play in supporting people with diabetes to use some of this technology as well. So that brings us to the end of today's podcast. Thank you so much for coming along and speaking around these non-pharmacological interventions, as well as the advancements in technology. And if you do have any further questions or any further passion around developing your knowledge and skill set around diabetes, then please do visit our website, which is www.educationforhealth.org, and you'll see that we have a range of academic, so higher education courses in diabetes, as well as also our CPD accredited workshops that are available to build your knowledge around diabetes, or equally if you want to refresh your knowledge around diabetes as well. So thank you once again for listening to our listeners, and also thank you, Georgina, for coming along and talking to us today.
Okay, thank you very much.